Good evening. Can everyone hear me? Can I be heard? Shobhrata, can you? Hello.
Yes, sir. You're loud
Yes,
and
you're
clear.
audible.
Can hear me. Okay. Okay. So good evening. Welcome to Kolkata Live, and we are just about to start. We are having this in two sessions. In the first session, we shall discuss calcified lesions and how to treat them, and in the second session, we will have in-stent restenosis and how to treat in-stent restenosis. There will be a keynote lecture at the beginning of the calcified lesion session, and that will be Dr. Deepak Davidson. Dr. Binayak Dev will introduce him. We know Dr. Davidson very well because we have interacted before and we have seen his cases. He's an expert in calcific lesions, intravascular imaging. So we are going to have, I'm sure, a nice presentation from him. After Dr. Davidson, there will be 2 or 3 more speakers. I think one of the speakers have not yet logged in. So we'll have Dr. Mandar Shah and Dr. Suman Chatterjee. And following that, there will be a discussion on some contentious issues in calcific lesions, and all the experts and panelists will be invited to join in the discussion. Dr. Binayak Dev, who is consultant interventional cardiologist at R.N. Tagore, Rabindranath Tagore, the same institution as me. He's the moderator for this session. So I invite Dr. Binayak Dev to take over the job of moderating the session and introducing the speakers and laying down some ground rules regarding timing, and then we shall kick off. Dr.
Thank you, Dr. Bhattacharya, for the introduction. So let me introduce first Dr. Devdatta Bhattacharya, who does not need much of introduction because he's a very well-known interventional cardiologist in our national arena. He's a clinical director and senior consultant and chief of cath lab services at NH Rabindranath Tagore International Institute of Cardiac Services, and he has more than 20 years of experience in interventional cardiology, considerable experience in peripheral renal and carotid angioplasty, with keen interest in imaging and physiology-guided PTCA. He has also extensive experience in rotablation, lithotripsy, and recently ever published many noted articles in national and international journals. So Dr. Bhattacharya will be he's our course director for this session, and he will be the moderator for the questions and answers sessions. So I introduce Dr. Deepak Davidson. As Dr. Bhattacharya mentioned, he's a very well-known person in the interventional cardiology in India, and he has plenty of experience in intravascular imaging. And let's hear from him the keynote lecture first. And then we'll have Dr. P.K. Sahu and Dr. Mandar Shah and Dr. Farhana Ahmed. Let us keep this presentations to 7 minutes with 3 minutes of question and answers, because we have plenty of presenters within this 2 hours. So I'll ask request the presenters to keep their lectures for 7 minutes. Followed by that, we'll have some interactions with our expert panelists. We have our expert panelist, Dr. Deepak Davidson from Writers in Heart Institute, Kottayam. We have Dr. Natarajan from AIIMS, Kochi. We have Dr. Pradeep Kumar Karmakar, who is the National Institute of Cardiovascular Disease and Hospital in Dhaka, Bangladesh. And we have Dr. P.K. Sahu from Apollo Hospital, Bhubaneswar. So these are our expert panels, and we have chairpersons in the form of Dr. Mandar Shah from Tata Main Hospital and Dr. Sanjeev Sen Gupta from Command Hospital, Kolkata. This is for the first session. So let us begin with the keynote lecture from Dr. Deepak Davidson. Over to you, Dr. Davidson.
Good evening to all of you. Sir, am I audible? Can you see my slides too?
Yes.
Yeah, we can see your slides.
Good evening to all of you. First of all, let me take this opportunity to thank Dr. Bhattacharya, Binayak sir, and Team Abbott for having given this opportunity, and to have the screen share with stalwarts in interventional cardiology, especially Natarajan sir and co. Over the next few minutes, I shall share with you imaging in calcified lesions, primarily based on OCT in calcified lesions. Now, if you look at this image, you could see here, this is the IVUS image, wherein you can see the arc of calcification. You could also identify the length of calcification. However, it is difficult to identify the thickness of calcification based on IVUS. However, we know that OCT, it penetrates the calcified segment, and so you can measure the thickness of calcification also. So then you can assess the volume of calcified segment compared to IVUS evaluation. So it's again the same thing. OCT penetrates calcium, so you are able to assess the thickness as well as volume of the calcification. Now, these are few images of calcification inside the coronary arteries. In this first image, you could see that this is deep calcification. You could see that this is the intima. The calcium is away from the intima, so it's a deep calcification, and it occupies almost one quadrant of the vessel wall. Now, here you could see that this is eruptive or nodular calcification, which is protruding into the lumen of the vessel. And the third one, you could see here that these are superficial plates of calcification. You could see that the calcium is very close to the lumen. So you know that these are all superficial calcification. Now, when you see deep calcification, you need to resort to traditional techniques, primarily balloon-based techniques. That's non-compliant balloon, cutting balloons, scoring balloons, and IVLs. When you see something like this, when you have an eruptive nodule or a calcific nodule protruding into the lumen, you could think of rotablation, that is ablative therapies. You could also use orbital atherectomy, which is not available with us. So rotablation would be a reasonable option in this particular situation. Similarly, when you have a superficial calcification, which is so close to the lumen, and when you have a very tight lumen, very tight stenosis of the vessel, in those situations also ablative techniques, that is atherectomy, rotablation, would be of great help. So when you have a deep calcification, maybe a rotablation may not be really helpful. One should probably resort to balloon-based techniques. Now, regarding OCT, what all information do you get? During the pre-procedure evaluation, you get an idea regarding the location of calcification, whether it's a deep calcification or a superficial calcification. You get an idea regarding the circumference, whether it's 90 degree, whether it's more than 180 degree, or whether it's 360 degree. You also get an idea regarding the length of the lesion, and you also get an idea regarding the thickness of calcification. Now, once you do the plaque modification, you could also assess with the help of OCT. You can identify thinning of calcification. You can also identify fractures in calcific plates, and when you have a wire bias towards a calcific nodule, you can also see that the calcific nodule has been shaved off with the help of the rotablation or ablative techniques. Now, we have this particular article that was published in 2018 by Fujino et al. We know that these are the three important points that they looked at. You look at the angle of calcification, that's the arc of calcification, the thickness of calcification, and the length of calcification, and you score all the three. And when you have more and more score, you know that the stent is not going to expand properly unless and until you ablate the lesion or you do proper plaque modification. You wouldn't have a proper stent expansion if the calcium score is going to be high. Well, I'll start with the case history of a 70-year-old gentleman who present with effort angina, had an angioplasty to the proximal left-handed descending artery long ago, almost 15 years ago. Now he has effort angina. You could see that there is a significant calcification in the mid left anterior descending artery, and this can be very well appreciated in the AP view. You could see that there is significant amount of calcification. We tried to do imaging, but then the imaging catheter wouldn't go in because of the tight stenosis there. So we went ahead with rotational atherectomy. That was an 1.5 millimeter bar at 180,000 RPM. Initially, it was difficult for the bar to go through. However, we were able to get across the lesion, and then we tried imaging that particular lesion. Here you could see that there is almost 180-degree arc of calcification. You could also see that as we measure the calcification, it's more than 0.5 millimeter. It's almost 1 millimeter in thickness, and you could also measure the length based on OCT. So here it's more than 5 millimeters. It's almost 15 millimeters. So we have an arc of calcium which is more than 180-degree arc, the thickness which is more than 0.5 millimeter, and you could also see that the length is more than 5 millimeters. millimeters. So we were sure that this particular patient has got a very high score, and it's extremely difficult. It's going to be extremely difficult for us to open this particular lesion. IVL is always an option in this particular situation, but because of cost constraint, we started off with non-compliant balloons. It wouldn't open up the lesion even at 20-26 atmospheres. Finally, we went ahead with an OPN balloon. We undersized the OPN balloon, and finally at 40-45 atmospheres, we were able to open the lesion with OPN balloon. And following OPN balloon, we could see that these are the OCT images. You could see that there are multiple areas of fractures in the calcification. You could see at 11 o'clock position, 7 o'clock position, the calcification has been fractured, and you could also see that there is a significant intramural hematoma there proximal to the lesion. So with the help of OPN, we were able to open up the lesion, and finally stent implantation, and we were able to achieve a reasonably good result in that particular vessel. Well, those are the areas where you have calcification, you have the fracture, and opening up of the stent has expanded the vessel very well. Well, this was an article, the Japanese article published in JACC in 2019. They tried to identify the sort of calcium that can lead on to acute coronary syndrome. They divided calcification into 3 groups. One, here you could see that this is eruptive calcification. You tend to see that it's mountain-like thing. It's an eruptive calcification. Here you could see that these are calcific plates, that is superficial calcific plates. And the third one, you could see that that's a calcific nodule protruding into the vessel. So eruptive calcium, the superficial plates, as well as the nodular calcium. When they looked at the reason what lesion produces more of acute coronary syndromes, they made out that the superficial calcific sheets, these are the ones that produces more of acute coronary syndrome, followed by eruptive nodules, and finally the calcific protrusion, it produces ACS in around 7% of situation. Now this was a patient who had an infemoral MI, who he was taken up for a primary angioplasty. He had a non-dilatable lesion in the mid-right coronary artery, and he was referred to us. We kept him on tirofiban for 12 hours because the ST settled down, and he was taken up for rotablation the next day. You could see that there is significant amount of calcification in the mid-right coronary artery, and it's a huge right coronary artery, more than 4 millimeter in size. We started off with an 1.5 millimeter burr. After 1.5 millimeter burr at 180,000 RPM, we did an OCT imaging. You could see that these are areas of superficial plates of calcification, very thin areas of calcification, less than 0.5 millimeter. You could also see that there were areas of thick calcification. You could also see that the wire is closer to the catheter is closer to the calcium there, which means that you would get a reasonable ablation at that particular area with rotablation. And you could also see that there are areas of nodular calcification inside the vessel. And finally, the mostly you could also see that eruptive nodule sitting over there. So you could see that in this particular patient who had an acute coronary syndrome, infemoral myocardial infarction, had all sorts of calcification inside the coronary artery, and 1.5 burr did not do much for that particular lesion. So we went ahead with a 2 millimeter burr at 160,000 RPM. That's a 2 millimeter burr rotablation. And following that, these are the images. You could see here that the wire is closer to this particular nodular calcium there. You could see that particular area, there is a burrow there, which means that something has been shaved off from that particular area. Here again, you could see that because of the wire bias, again, something has been shaved off, and that was an area where we saw an intimal tear also. Finally, we went ahead with balloon dilatation, that's stent implantation, and following 4.5 millimeter balloon dilatation, you could see that we were able to achieve a reasonable flow inside the vessel. Now, that's my third case. You could see that this particular patient had a effort angina class 2 presented with treadmill positivity, taken up for angiogram. You could see that the left main bifurcation, there is a tight stenosis at the left main bifurcation. You could appreciate it better in the AP cranial view. You could see that there is significant amount of calcification at the left main bifurcation. It was projecting into the that's the AP view, wherein you could see that the calcium is actually projecting into the circumflex as well as into the left anterior descending artery. And that's the image wherein you could see that there is a shelf-like lesion over there, which is actually it was difficult to identify what sort of lesion it was based on the angiography. We tried to do IVS evaluation. We made out that there was significant amount of calcification there at the bifurcation, but we were not able to get a proper image of that particular area with with IVIS. So we thought that we should also evaluate that particular area with OCT. So OCT imaging was done. Here you could clearly see that this is the left main. I'll show that. Okay, this is the pullback from LED. You could see that there's a protruding huge nodule at 3 o'clock position there, and you could also see that there is a huge nodule that is protruding at 6 o'clock position. So you saw two nodules protruding there into the lumen. That is one nodule over there, and this is the second nodule, and you could also see that this is the circumflex ostium. So it's basically at the left main bifurcation. You saw that there were two nodules on either sides of the circumflex artery. You could see in this particular bifurcation mode that at the origin of the circumflex artery is almost a slit-like thing over here, and this is a nodule there are two nodules on either sides of the circumflex ostium. So we thought that we might get a better good ablation because it's a slit-like ostium. So when we try to do rotablation of the circumflex, we might get some ablation of this particular nodular calcium. We ablated the left main into LED and then into the circumflex. In ablation into the circumflex was difficult with rotablation. At around 200,000 RPM, we were able to ablate the circumflex ostium. Now you could see that these are the comparative images, the first image and the second image. If you look at the first image, you could see that this particular area, the wire is actually closer to the calcification, which means that this particular nodule can be ablated with the rotablation. So in the second image, you could see that there is a furrow created over there. That was the area wherein you had the wire sitting close to the nodule, and so ablation has been done properly. Moreover, if you look at the slit-like ostium in the first image compared to the second image, you could see that the ostium looks much bigger following a rotablation from the left main into the circumflex. So we made out that based on OCT imaging, we made out that there was significant amount of calcified nodules at the bifurcation, and it was properly ablated. In the 3D image, we were able to clearly identify the slit-like ostium of the circumflex also. And finally, we did rotablation, angiosculpt was used, and finally a DK crush technique was used to do the final modification of the vessel, and that was the final image following stent implantation. You could see that angiographically it looks good, and the circumflex ostium looks good, even though you're able to see the small amount of nodular protrusion at that particular area. You're able to see that the circumflex mouth looks really good in the OCT. Now this is the data that says that when you have an arc of calcium that is more than 227 degree, and if you have a thickness less than 670 microns, you are likely to fracture it with rotablation as well as a cutting or a scoring balloon. Here, if you look at this particular image, the calcium starts at 4 o'clock position, goes all the way around until 3 o'clock position. So more than 220 degree arc of calcification. And you see that there is a thin area over here, which means that following rotablation and following balloon dilatation with a cutting balloon or a scoring balloon, you will be able to break that particular area. That's the data says, more than 220 degree arc of calcification, and the thinnest area should be less than 670 microns. Now that's my last but one case. This was a patient who had a bypass surgery, had presented with recurrent rest angina, had multiple stenosis of all the vessels, underwent stenting to the circumflex as well as right coronary artery, and also had stenotic calcific stenosis in the left antedescending artery. This is just to highlight the usefulness of IVL in nodular calcification. We did an OCT evaluation. You could see that there is some deep calcification. You could see that there is some nodular calcification. We were happy seeing that because the catheter is closer to that particular nodule, which means that following rotablation, we may be able to shave off that particular area. So that is the area wherein you could see that superficial thick calcification, and you could also see that it's almost 180 degree arc of calcification over there. So we went ahead with rotablation. Following rotablation, you could see that that's the area where the calcium nodule has been shaved off with the rotablation. That's the area where the shaving off has been done, which is clearly made out with OCT. And then again, we made out that there was deep calcification also. We went ahead with IVL, 3 to 12 IVL. And following IVL, you could again see that that's the area where you could see that that's a fracture that was created by the IVL. So finally, that's a fracture which is clearly made out in this particular image. Finally, went ahead with stent implantation, and we were able to achieve a reasonable flow in that. That's the final result. And this is my last case. This particular patient had undergone angioplasty with a bare metal stent to the left antidistinct artery, present with an anti-wall myocardial infarction, underwent thrombolytic therapy, and he was taken up for a procedure. You see that the left antidistinct artery at the stented segment has got tight stenosis. We evaluated with OCT. You could see that these are areas wherein you could see that there is almost 180-degree arc of calcification inside the stented segment. So this calls for a neoarthrogenesis. So you have a tissue growth inside the stented segment. You are able to see the stent clearly. The tissue is seen inside, and inside the stented segment, you are able to see 180-degree arc of calcification. We were also able to see microvessels, areas of plaque rupture, and spotty calcification. So this was a neoarthrogenesis in this particular patient. And if you look at the data says that inside the stented segment, if you have a neoarthrogenesis, and if you have an angle of calcium more than 180-degree arc, and if the thickness is more than 0.5 millimeter, then it's extremely difficult for you to expand the second stent inside the stented segment. So when you have neoarthrogenesis, look at the calcium. If it's more than 180-degree arc, if it's more than 0.5 millimeter, if it's in thickness, then you have to be very aggressive with that particular lesion. You have to go ahead with a cutting balloon or a scoring balloon or an ablative therapy. And finally, we went ahead with a cutting balloon angioplasty in this particular patient's 48 millimeter expedition. And that was the final result that we could achieve in this particular patient. So, dear friends, OCT imaging modalities would definitely help us to identify what is the thickness of calcification, the extent of calcification, whether it's a superficial calcification or a deep calcification. And that would finally help us to identify what is the ideal tool, whether it has to be balloon-based technology, or probably we need to go for rotablation in these particular situations. That's the sort of information that you would get with OCT. And post-procedure, following plaque modification, if you make a fractures in calcification, you're sure that you're going to have a proper expansion of the stent. And just a point to remember, when you have a stent expansion, when you have an eccentric stent expansion and malapposition in areas of calcific nodules, do not be very aggressive at that particular area, because you are likely to have the vessel rupture, because the nodules are not going to give way with the help of balloon dilatation. Thank you once again. And let me also take this opportunity to once again thank Bhattacharya sir as well as Binayak sir for having given me this opportunity. Thank you so much.
Thank you, Dr. Davidson, for your wonderful lecture. Dr. Bhattacharya, if we are okay, we can go ahead with the second presentation by Dr. P.K. Sahu, followed by the questions.
I think.
Or do you want?
Yeah,
do you want to have a couple of discussion points on this lecture first?
Yes, I think the first two cases, there were a lot of cases presented. We can't discuss all of the cases, but the first two cases, I think we should have a brief discussion, and we will discuss the other cases later on if possible. So, okay. Yes, Dr. Davidson, wonderful cases. The first case that you showed where you did rotablation and then you had to do a high pressure balloon dilatation with an OPN balloon. The burr was it 1.5 or 1.25?
So it was 1.5 millimeter burr. We were working with a 7 French guide catheter through the radial approach. In spite of that, when the balloon dilatation did not happen, we tried with a 1.75 millimeter burr, but because of some problem, the burr was not going through the guide catheter, even in spite of it being a 7 French guide catheter. So we had to be satisfied with an 1.5 millimeter burr.
Okay. So, and after that, you did OPN balloon dilatation at 45 atmospheres.
Yeah,
right?
yes.
A 3 millimeter balloon. So this is something that has always intrigued me, that whether there was a risk of rupture if we used high pressure balloon dilatation in this situation, but it was concentric calcium. As far as I remember, so what it showed very elegantly on the subsequent OCT was that there was actually fractures in the calcium plate, very similar to IVL. You see the same appearance with IVL that you showed with the OPN balloon. And this is very reassuring that this can be done safely. Because if, as you said quite correctly, that if there was eccentric calcium, you can actually rupture a vessel by balloon dilatation if you're not careful, because the balloon expands only in one direction. But probably the risk is lesser in concentric calcium, which you have demonstrated in this case. And this is very nice. And after that, the stent expanded very nicely. And the second case that you showed, the left main, where you showed very nicely the calcium at just at the junction of the left of the circumflex and the LAD straddling across the two vessels. And what I wanted to just point out to the attendees here who are watching this case is the position of the guide catheter as he did the LAD and the circumflex when he was doing the rotablation. If you had watched closely, you would have noticed that he had pulled the guide catheter back when he was doing the circumflex and aligned it towards the circumflex so that it is easier to actually rotablate the circumflex. And this is very important. When you have that angle in the circumflex, you have to do a little manipulation of the guide catheter before you actually do the circumflex to LMCA rotablation. And again, wonderfully done. And even after that, the OCT images were very, very good. And the final result was excellent, a DK crush in this situation. Very, very good. There are things to discuss about all the cases, but in the interest of time, I think we'll go on to the presentation of Dr. Shahu. And Dr. Dev, remember, Dr. Mandasha has to leave a little early. So we will have to accommodate him.
Mandasha, does he have a case? Do you have a case to present, Dr. Shah?
He does have a case. That's what he said.
No, sir. You don't have a case. He's an expert panel, sir.
Do you have a case, Dr. Shah? You said you had a case to present?
Yes, I do have a case.
Okay.
If we do have some time.
Yes, I mean, what's the time now? You'll
7:30 now.
Why don't you go ahead and present your case, Dr. Shah?
Dr. Shah has to leave, Dr. Bhattacharya. I think he has to leave at 7:45. Leave. So let him present his case.
At 7:45. Okay, I think in that case we'll go ahead with Dr. Shah because he had slotted in earlier.
Yeah.
And then we'll accommodate Dr. Shah. Dr. Shah, please. Yes. Good evening, Dr. Shah. Please.
Good evening.
Please finish within 7 minutes. Then we'll get Dr. Shah to speak, and then we'll discuss both your cases together.
All right. Can you see the slides?
Yes, we can.
Yes, we can see your slides.
So I'll quickly go through this thing. It is basically on instant restenosis. Now we know that these are the statistics which tells us that in POBA it is up to 50%, in BMS 30%, in less than 10% in DS. Now we are all aware of the various mechanisms of how which instant restenosis occurs. So this new atherosclerosis, drug resistance, plaque prolapse, intimal hyperplasia, hypersensitivity, fracture, geographic miss, and underexpansion. All these can cause this thing, instant restenosis. Now, one has to be very clear about the types of instant restenosis. First is the homogeneous type, which you get on OCT. Next is the heterogeneous type. This is the classical picture of where you get a heterogeneous one. Next, you get a lipid-laden neointima. This is the third type of ISR. The fourth type is a TICFA, the thin fibrous cap fibrous atheroma. Next is an intimal disruption can also take place. Next, a macrophage infiltration where you can see the macrophages very clearly, or there will be neovascularization, or you can just have thrombus, or you can have a persistent low intensity area. So these are 9 types of ISRs that you can get, images you can get in OCT, and you have to, all depends on what type of ISR you have, and accordingly you plan your strategy. Now, it all depends whether it's a mechanical factor. You have to have a liberal use of IVS or OCT. If there's no mechanical factor, you can just use a cutting balloon or a scoring balloon, then with drug balloon angioplasty and or repeat stenting with another generation DS. But if the stent integrity is compromised, if there's a fracture, edge, or a gap, then, or if there's underexpansion, you have to take the proper strategies and finally do a stenting. Now, if I have to summarize the strategy for ISR, if there's an unstented or a gap segment, just with POBA, put a DS. If there's neointimal hyperplasia, POBA, laser or DS. Stent fracture, POBA, DS or brachytherapy. Undersized stent, start with NC, OPN, a scoring balloon, or a large. More important, underexpanded, again, you have to use a larger DS after using an NC or OPN. Or use this thing, cutting balloon. You can also use it. Or if the 2 layers of stent, again it comes with the instant restenosis, definitely laser or brachytherapy, or just a drug coating balloon. So now I'll just present two cases. This is a 62-year-old male, hypertension, diabetes, dyslipidemia. In 2011, he had unstable angina. And this is a film that you can see that he has a LAD, which is subtotal occlusion, and also an OM lesion. These are the two lesions he had. And this was the angio, where you can see the stenting has been done with the cipher way back in 2011. The results are good. And this was the pre and the post stenting results. And the OM lesion was also stented. And these are the pre and the post lesions stented of the OCT after on angio. 9 years later, when became 71 years, he already had gone a spine surgery, a TURP, fairly controlled diabetes, lipids and hypertension well controlled, presented with angina, class 3. TMT was positive in 2020, but he kept on avoiding an angio in view of the COVID times. Again on 22/6/20, he again had unstable angina, and an angio was done on 23rd of June in 2020. What we saw was that the whole LAD, not only the whole LAD was re-stenosed this time, but also the circ was also, the OM was also re-stenosed. So this is what we got. We did an OCT of the this thing that is LAD, and we could see the different segments. You can see that there is new hyperplasia, and there is some amount of calcium over here also. Now, there was a long segment involved. Basically, the stent was undersized because we never used any imaging that time. There was significant luminal narrowing. This was homogeneous in nature and extensive mesenchymal proliferation. So the strategy was to debulk with a cutting balloon, then use a NC, use a larger size stent, which has to be very important because you had used an undersized stent, and post-dilate at high pressure, check the expansion and of course the apposition OCT. So this was a cutting balloon been used, and after the cutting balloon, you can see we have got some good results. And then we went with this thing, stent, Zyne stent 3x38 was used, and after this was the result. And this is what you see. It was a pre and the post. And then if you see the post-stented results, it shows a very well this thing expanded stent. The second stent has been well expanded. Next, it was for the this thing that is OM, but the OM was difficult to image with an OCT. So here what we did, basically we did an this thing that is IVUS. We can see the pre-stent OM, and after that it was stented. This was a post-stented IVUS because it was difficult to take the IVUS catheter, OCT catheter down over here, and there was not much of segment beyond the re-stenosed segment. Now, I come to my second case. This is also an 8-year-old story, 45-year-old male who had undergone a PCI to RCA, TMT positive. There was a focal lesion in the stent. Now, first, when we dilated with the this thing post NC, this case was just done last month. In fact, there was a lot of waste in this NC balloon. It was an unyielding this thing lesion that you can see when we dilated with a very high pressure with the NC balloon. After this, we thought I went with the cutting balloon was used, and still with the cutting balloon, you can see some this thing waste has gone off. It has yielded already, and this was. After that, we still saw that because after the cutting balloon, I went with an OPN NC and went to very high pressures, and then finally stented with the second stent. Let us go through the OCT images. You can see what you can see is just a focal ISR. There is homogeneous non-intimal this new intimal hyperplasia that you can see. Very clearly it can be seen, and it is homogeneous in this thing nature, and just a spot lesion was there. And this was a post-cutting balloon where you can see that the post-cutting balloon, it has debulked this this thing spot lesion, and you can see the cuts that has taken place. And then there was a stent that has been used, and this is the final result where a second small, very spot stenting has been done, and you can see the apposition index showing that it is very well apposed, and the expansion is also very good. As you can see that the expansion is to the tune of 90%. So this comes to the fact that why is OCT preferred imaging in ISR? Because the resolution is about 10 times higher than the intravascular ultrasound. It identifies the stent struts very clearly and accurately, and defines and quantifies the relationship with the vessel wall. Evaluation of the stent strut coverage, apposition, new intimal hyperplasia is very important. And so if you use an OCT in ISR, the challenges are very easy. Meticulous analysis of OCT images is essential for planning the strategy. More useful in proliferative ISR than underexpansive ISR. Second stent required for homogeneous and neoatherosclerotic ISR. These are the take-home messages that one should utilize by considering OCT in cases of ISR. So this is like what we use in ISR. When you do an angio, you don't know what is going on. But if you have to update yourself, you have to take an OCT and have to be a little bit intelligent, and it saves a lot of extra effort and ultimately give good results to the patient. Thank you very much for the patient here.
Thank you, Dr. Sahu, for your wonderful presentation. We'll ask Dr. Mandar Shah to have his presentation, to do it within 7 minutes. Then we can go for the discussion. We can see your presentation.
Am I
Please
audible?
unmute. Yeah, you are audible.
Fine. So, good evening, everybody. First of all, I'm extremely embarrassed and ashamed to be presenting this case because the mistakes which I committed on that particular day, I don't think I would ever have committed anytime else. Well, that was a fag end of a very busy day, and not giving this as a justification, but the fact is that everybody was tired out. Myself, the technicians, the nurses, and we did not want to take this case up in the evening hours, but we are compelled to do so because this patient we had to postpone for some reason or the other previous 2 days. So we felt compelled and obliged to do this later in the evening after a very busy day. So this is a 60-year-old lady, known diabetic hypertensive multinodular goiter, presented with chronic stable angina. Past history of angioplasty to LAD and circumflex 3 years ago with normal LV systolic function. And you can see a patent stent in circumflex, patent stent in LAD. Distal LAD close to apex is subtotally occluded. And RC has got de novo lesions which were not there 3 years ago. Both proximally in mid segment as well as distally. So we thought that we'll put a stent distally, put another stent covering from proximal to mid segment and come out. So this I'm showing just to show that there is no obvious visible calcium or anything. So we thought that it should not be too difficult a case. We passed wire, balloon dilated the proximal lesion, the distal lesion, mid and proximal lesions, but the stent refused to cross. Now this could be because of the angulation, it could be because of tortuosity, non-alignment of catheter, or some occult non-visible calcium. So what we do normally in such a case is take a buddy wire, and this is once we have pre-dilated and once there is dissection, then this is the manure which we prefer, Hemlich-like manure, where we give hairpin bend like shape to the distal end of the wire so that it does not get trapped into the dissected segment, and it minimizes chances of going into false lumen. So that is what we did. And we stented the distal segment. As you can see, the stent is not uniformly expanded, possibly because of calcium or fibrosis. But immediately we realized our folly after that. We missed retrieving the buddy wire. So retrieving buddy wire is okay. So very often we do keep buddy wire, and after deployment of the stent, we do retrieve it. But here we had used an Oxford hydrophilic wire, which was having a hairpin bent distally and in a likely calcified or fibrotic lesion. So all are not good substrates to leave buddy wire in situ. So my technician said, sir, don't worry, it should not be hopefully a problem. You just retrieve the wire, and once it comes to the edge of the stent, the wire will straighten out and just pull it back, like normally how we straighten hairpin bend with help of a balloon, something similar to that. But when we did that, you can see that the buddy wire has got trapped at the distal edge of the stent. And the more we tried to pull out, the more it kept on getting entrapped. So now what to do? So we had to remove the trapped body wire at any case. So one of the ways we thought was to take a small 1.2 or 1.5 millimeter balloon over the trapped wire and try to create space between the stent and the vessel wall, and using that plane, freeing up, or possibly the wire might come out. So that was the logic. So we took 1.5 millimeter balloon and kept on dilating it as much as it went over the trapped wire. So it could go almost till half the stent, and beyond that the balloon could not go. But then what we did is, with whatever space we had created, kept a gentle tug on the balloon and the wire combined together, and kept on gently pulling it back, and thankfully the whole thing came out. But in the meantime, we had already distorted the stent proximally by our balloon dilatation and distally because of the entrapped wire. So the flow was well preserved, but obviously this was not a stent we were going to leave it like that. The proximal part of the stent, which we had deformed by balloon dilatation, we pre-dilated that segment, or whatever, post-dilated that segment, but the balloon would not go across the distal end, the distal deformed strut. Even 1.5 millimeter balloon would not go, basically because if we tried to push that 1.5 millimeter balloon, the guiding would back off. So then we had to take help of another body wire. We are not sure it went through the struts or from wherever, but we were not bothered. It was used only as a support, and over our original wire, we took this 1.5 millimeter balloon, which then surprisingly went easily. And then we dilated the distal deformed stent. Now the bigger balloon could cross, and we dilated the lesion. And once again, the stent, now we wanted to stent across this segment and cover up the entire lesion, but the stent could not be negotiated. So passed a body wire again, and to our whatever dismay or ignorance, fatigue, tiredness, once again we missed retrieving the trapped wire. Fortunately, this time it did not give any problems. We had not gone with a hairpin bend, and it was not a hydrophilic wire, so it did come out easily. And this was the result. The third stent again could not be negotiated without a body wire. Once again, we needed to take body wire inside, and then proximal part was stented. Then, of course, we completed the post dilatation serially, and this was the end result. So final gratifying result, but some thing which should never have happened, completely iatrogenic, completely my fault. And this is what we finally eventually ended with this patient. Now we have been following up for past 3 months, and the touchwood patient has been doing well.
Thank you, Dr. Shah. Dr. Bhattacharya, you can involve Dr. Natarajan and Dr. Pradeep Kumar Karmakar in our discussion. Yeah.
Please
Yes.
please introduce Dr. Natarajan. Ask him to pass his comments on first Dr. Sahu's case, and then Dr. Mandasha's case.
Yes, Dr. Natarajan.
Dr. Sahu, my good friend, his cases were self-explanatory. So most of the points that he had to stress about instant restenosis, particularly with the the importance of OCT imaging in characterizing the instant restenosis, under expansion versus exuberant neointimal hyperplasia, and the differential approach based on these two he very nicely elucidated. As regards to Dr. Mandar's case, the hairpin, most often it actually forms as you try to negotiate the vessel. You don't have to actually have to form, make the hairpin in vitro. Oftentimes, when it hits the previous stent itself, it forms a hairpin. Dr. Bhattacharya can add to what I'm saying. You don't have to make a very acute hairpin, which actually complicated the case. That's what I feel. And also a guide extension catheter would have come in handy in the case that you showed.
Yes.
Oftentimes the hairpin forms by itself, isn't it?
Yeah, I think what he meant was that he had dissected the proximal RCA and he was trying to not enter a dissected segment. And so that is, I think that is, if I understand right, that was what he was trying to say, instead of actually trying to cross the stent. Is that right, Dr. Shah? Is that what you were trying to say?
Yes, that is what, because the proximal segment was clearly dissected and we did not want to enter into false lumen. So then we did create this bend outside.
All of us have done this mistake of leaving a buddy wire when stenting. And
Yes.
particularly when you use a very long stent, like 38 millimeter or more than 38 millimeter, in a calcified vessel, that is the time this trapped buddy wire can give rise to trouble. Oftentimes it actually comes out. But longer the stent, the problem is more, particularly in vessels with calcium that was otherwise missed, as you very correctly showed in your case.
Dr. Shah, why did you take out the initial wire first? That was your lifeline, in fact.
No, we did not take out the initial wire.
We couldn't see it. That is, I think that is the point Dr. Shah was making.
No, we did not take out.
It was there. Okay.
The wire was very much there.
It was difficult to see it on the pictures.
I see.
We take it at your word that it was there. No, this is particularly a problem if you do it in the right coronary artery. It rarely is a problem with other arteries because the right coronary artery has its first major branch so distally, and you can get a whole length of wire trapped in the right coronary artery, and it is very difficult to pull it out. And I have done it once myself. And I think if anyone comes across this complication where they have inadvertently left the wire, the first step that you should do is actually not pull the wire, but take a balloon on that trapped wire and get underneath the stent. What you did in the end, do it first. Just dilate the stent, create the undersize of the side of the stent, create some space, and the wire will slide out. Instead of pulling it and deforming that stent, this would have made life a little bit more easier. But I'm sure you're wiser because of the experience, and you will know what to do if it happens again, or if some of your colleagues manage to do it and then ask for your help.
Dr. Manda, can I have some?
Yes, Dr. Karma.
Yes, please.
Yes, thank you very much to face a very difficult case. I have some query. What was your initial wire?
It was an Oxford hydrophilic wire. I think that's what he said.
The buddy wire was Oxford hydrophilic wire. The original wire was BMW.
BMW. What was the stance? Long stand. Which stands you are using? Because there are some stand is easy trackable. There are some stands not trackable. Especially at the Boston, that stands are hard. Especially you are using the long stand. Which are the stands?
Yeah. So in this particular case, this was a Zions stand. A Zions.
Stands? Sorry.
Both
stands from Zions?
Yes. All three were from Zions.
Yeah.
What if it is my case? What I did, because you are using too long stand in the RCA, and you are failing to do there is a problem in the crossing. So in my lab, I usually use the Grand Slam. It is a very good wire for tackling this long lesion or the trackability problem. It may overcome only by using the Grand Slam.
Yeah, what you mean is that it straightens out the artery a bit more, and it helps. It gives you more support. Yeah, I think apart from the wire, I think the other thing that he could have done was mentioned by Dr. Natarajan, and that is take something like a guidezilla.
Maybe fibro, but there is the obvious calcium.
Actually, initially, looking at the lesion, I never thought that it's a calcified lesion.
Yeah,
When I went in, I thought it's a straightforward case. I never anticipated that.
The distal lesion really looked bad. I mean, the distal lesion was a fibrotic lesion, and it's a case of chronic stable angina. So we have to anticipate these things when the whole of the right coronary artery is diseased, and you have to stenting the distal RCA is difficult if you have a lot of disease proximally, and you have to make some provisions for it. I think we'll just take some comment from Dr. Davidson on Dr. Shahu's intravascular OCT images, and then we can go on to the next case. I think Dr. Suman Chatterjee is here.
Dr. Farhana Ahmed from Bangladesh is started for the next case.
Suman Chatterjee was there in the first
He's
session.
there for this. He's there in the second section.
Okay. Okay, that's up to you to sort out, Binayak. I think we'll take one comment from Dr. Davidson, and then we will go on to the next case.
As usual, Sahu sir, it was wonderful and so informative. And your slides are all quite awesome, as usual. It's wonderful. Sir, just one point regarding the second case, wherein you had difficulty in dilating that particular lesion. We expected that there is significant amount of calcification, something like a nodule or a thick calcium, which ultimately you had to dilate with a OPN balloon with at very high pressures. Now, we didn't really make out that sort of significant calcification on OCT. So what do you think was the reason why we were not able to dilate that particular area? In spite of not having significant amount of calcification or significant fibrotic plaque at that particular area. Sir, just one comment on Dr. Shah's case. We, as Natarajan sir has told, we all come across these sort of cases, and we never try to present these sort of cases in any of these forums. And I should really appreciate you in bringing out this particular case and presenting in such a good forum. And one point regarding that, regarding your case, you meant hydrophilic wire, or was that a polymer jacketed wire? Presently, we also have data that even if have a polymer coated wire caged, a buried wire, if you convert a polymer coated wire as a buddy wire, and then you, unfortunately, if you bury it, you can always pull it out. That is what presently data says. So you could always bury or make a buddy wire with a hydrophilic wire or a polymer coated wire also while doing bifurcation. Sahu sir, what could be the reason for that?
I think, Dr. Shah, can you show us that image once again that Dr. Davidson was talking about? There was a very focal stenosis in that, and I thought it was calcific. Just, I could be wrong. Just show that image, that OCT run again, if you can. Is Dr. Shah with us still, or he has left?
Sahu sir, you're muted also.
The lesion was.
I'm there.
Dr. Shah, can you quickly show us that OCT image?
Yes, I'll just show you the OCT.
But what could be the possible reason for?
Yes, if you see this picture.
Yeah, I can see it. Can
you see the calcium over here?
Yeah, just point on the screen.
Yes,
point on the long view layout. Point on the long view layout where you think.
The long view layout.
Yeah, there. Where your pointer is. That is the area.
That is the part of the calcium.
Yes. So I think
this would not yield at all.
Yes,
the whole thing.
Yes, that is what I think. That is calcium.
Yes, this you can see it here also.
Yes. And
the stent is very well opposed, but
yes, stent is very low. I think Dr. Davidson also made this point that if you have it eccentrically, then what you can see very clearly is the stent has not expanded in that direction, but in the opposite direction. Yes. And it is important to recognize this and not try to keep dilating. Here, the stent was well expanded anyway, but if you keep dilating these areas, here again, you can see this. This is the pre-image. I think, what is your comment on this, Deepak?
Yes, sir. I feel that's calcium. Now looking at this image from 11 o'clock to 3 o'clock and then 3 o'clock to 7 o'clock, it looks calcium in retrospect. In retrospect, at least.
Yes. I think
actually,
I agree.
Actually, what you see on longitudinal view, I thought it is only fibrotic lesion, but it would never yield. That's the whole thing. See, one side it yielded, the other side was not yielding. This side was not yielding.
Yes.
There was calcium.
Yes, I mean, it's sometimes in the first, probably in the first index case, this was not recognized, and that area was underexpanded, and that area led to the restenosis later on. And it is possible that the calcium, to a certain extent, was already there, and that over the time it had become worse. So I think
almost 9 years old. So actually, it must have calcified badly. That's the whole thing.
Yes. So that sorts it. I think we all agree. Do you agree?
Was it a case for lithotripsy for better stent lesion preparation in this case?
Excuse me,
in hindsight, now that this area did not expand to the way you actually intended to expand this area, though you have good stent expansion with OCT, still there is minimal under expansion at the place where there was calcium. I was just asking a question whether lithotripsy would have made things even better. Now it's very good actually. Would it have made it even better?
Definitely. But I had already exhausted quite an amount of money on a cutting balloon and an OPN. So I was not having the guts to put another lithotripsy on this patient.
I think the OPN,
and you can see now this
out for you.
Yes. And you can see in the final results, it is well expanded. You can see it is yielded to some.
No, we agree. Thank you very much. Thank you very much. If we can, Binayak, please take over.
Yeah, we'll move on to our next case by Dr. Farhana Ahmed from Bangladesh. She is a consultant interventional cardiologist at National Institute of Cardiovascular Disease and Hospital at Dhaka, Bangladesh. Over to you, Dr. Ahmed, for your presentation. If you could limit it to 10 minutes, then we can have some discussion on your case again. Thank you.
Good evening. Am I audible?
Yes, you are audible.
Thank you.
Share your screen.
Yes.
Yeah, we can see your screen.
Good evening. Thank you. First of all, thank you all for having me in this prestigious session. My presentation is Preparation is Everything for Success. I'm Dr. Farhana Ahmed, working as an assistant professor in National Institute of Cardiovascular Disease. Coronary calcification are associated with impaired stent delivery, stent under expansion, stent malposition, and age dissection. I think the answer is all of above. And 30% of the patient undergoing PCI have calcified lesion, and heavy calcification still represents a major challenge for successful PCI. Usually it is considered as an enemy for optimization of PCI. So adequate lesion assessment by IVUS or OCT or lesion preparation through calcium modification is crucial in ensuring procedural success and reducing adverse cardiovascular outcome. And the Horizon AMI and acute coronary calcium, this study also support that the calcified lesion have death, cardiac death, MI and TLR and MACE ratio is higher than the other lesion. And increased coronary calcification, higher pressure to dilate effectively, higher number of dissection, decreased stent expansion, more complication, and then leads to poor outcome. Nowadays, there are several calcium modification tools available like NC balloon, angiosculpt, cutting balloon, orbital or rotational atherectomy, and nowadays IVL and cis-open balloon is also available. And it is very common, popular algorithm to treat the heavily calcified coronary lesion. If the lesion is nodular, then the orbital atherectomy or rotational atherectomy might be a choice. If the calcium is moderate to severe superficial calcification, if it is balloon crossable, then IVL and rotational atherectomy might be a choice. And if it is balloon uncrossable, in that case, orbital atherectomy and rotational atherectomy is a choice. And if it is mild calcium, then we can treat it with NC balloon, scoring balloon, or cutting balloon. And my case is a 63 years old gentleman presented with chest pain. And the patient had previous history of CCS3 angina. Patient is hypertensive, a smoker. Patient on admission, he was hemodynamically stable. But the patient's troponin I has 3 nanogram per ml, that is, it is elevated, and EKG showing there is a extensive T inversion in almost all chest lead. And echo showing inferior valve is thin echogenic akinetic, and there is hypokinetic anteroseptal valve. So we're dealing with a case of non-STMI. And later on, patient developed ongoing chest pain, so we decided to take the patient to cath lab. And left system showing there is a tight lesion in mid part of LAD, and there is a calcification, trump track calcification is visible even in coronary angiogram. There is also lesion in LCX, tight lesion. And RCA, there is 100% occlusion, CTO lesion. As the patient have ongoing chest pain, we want to revascularize the patient. EBU guide catheter was hooked to the left system, and the LAD lesion was tried to dilate with 1.5 balloon initially. After dilatation with 1.5 balloon, the patient chest pain is subsided. And then we did IVUS. And I was showing there is almost 360-degree arc calcium, and there's acoustic shadow behind the calcium, which reflect the calcium is thicker. Sorry. And there is also lesion in LAD ostium, significant lesion in LAD ostium too. That was underappreciated in coronary angiogram. So we decided, as the lesion, there is a thick superficial calcium in the very tight segment, we decided to go for rota and put a stent covering the LAD ostium. But at that time, our rota system was not prepared. That is why we quickly switch our plan. We fix the LCX lesion first. Putting a 2.733 into 38 stent. And after preparing the rota system, we did rota of LAD lesions with 1.5 rota bar. And after rota ablation, you can appreciate there is a significant crack. There's a significant crack and a new appearance of new reverberation that indicate there is a successful rota ablation. And after that, we take 3 into 38 millimeter stent, put in LAD covering to the LAD ostium. And then post-dilation was done. And this is the final result. And you appreciate from the EKG, there is a resolution of the T inversion, which was found before the procedure. My second case is a 58 years old gentleman presented with chest pain on mild exertion. Patient has CCS3 angina. Patient was hypertensive, diabetic, and smoker. Patient was hemodynamically stable on admission. And on angiogram, there is a very tight lesion in proximal LAD, also in LAD ostium. And right system was normal. We did IVUS. And I was showing there is again a very thick calcium, almost more than 270-degree arc. It is superficial, thicker calcium, and left main is also diseased. There is a disease in the left main also. In this particular case, as the lesion is balloon crossable, we decided to go for IVL. IVL is a device that is very much tissue selective, hard on hard tissue, soft on soft tissue, designed to disrupt both superficial and deeper calcium and effective lesion expansion and minimize impact on healthy tissues. So we did IVL with 2.5 into 12 millimeter, and give several pulsation IVL wave. And after doing IVL, you can appreciate there is a crack in the calcium. There's a crack in the calcium. And this indicates the IVL is successfully prepared the bed for further PCI procedure. So we again pre-dilate the lesion with NC balloon at high pressure. Then we put initial stent. We put actually two stents, one covering the middle part of the lesion of LAD and another from the proximal to left main. Our initial finally, one stent covering the left main ostium, and port was done. And this is the final result. And IVUS, final IVUS, also showing there is no dissection, appropriate apposition of the external strut to the vessel wall, and there is appropriate coverage of the left main ostium. And this is a very landmark trial for use of IVL, Disrupt CAD 1, 2, and 3 trial, all showing there is a very short-term and long-term good prognosis, procedural success, as well as patient prognosis with use of IVL. So my take-home message is, coronary artery calcification continues to increase in prevalence in parallel with an aging patient. PCI of calcified coronary artery lesion remains a persistent challenge in contemporary interventional practice. Growing use of intravascular imaging to inform a strategic treatment algorithm is proving critical to optimal patient management. Newer device technologies increasingly facilitate more complete and effective revascularization with superior short and long-term patient outcome. In our case, use of IVUS, ROTA, and IVL made our procedure life in cath lab easier in decision-making and treating the patient. Thank you all for your patience.
Thank you, Dr. Farhana Ahmed. I hand over to Dr. Bhattacharya for his questions.
Thank you, Dr. Ahmed. I think if we can look at your IVUS images again, then we can discuss it. So first, could you please show us the LAD IVUS run, the first pre-run, and tell us once more about your interpretation. This one, yeah, this is the one. The first case, yeah. Not the first case, sorry, the second case, Show us the second case, where you did IVL. Yeah. Let us. So you're doing a pullback from the distal LAD, I presume, and here the vessel is 2.25 or something like that. This is quite distal. We are coming in, that's a branch, so this is okay. And here is your calcium, okay.
This is not a very long segment calcium.
So what was the length of the calcium?
5 millimeter.
5, okay. Now, there is only one comment I want to make about your interpretation, and that is regarding the thickness of the calcium. OCT probably is better, much better than IVUS in telling you about the thickness of the calcium, and you can never be sure. Although I agree that about your comment that if you see reverberations, it means that the calcium is disrupted, and it is, if you have reverberations at the outset, then it is thin calcium compared to no reverberations where it is likely to be thicker calcium. And in this case, did you try pre-dilatation with a high pressure pre-dilatation, or you went straight away with a IVL balloon?
Sir, we only did pre-dilatation with 2 millimeter balloon, not at very high pressure.
Okay.
Before IVUS.
See, my comment regarding this case is that if you can just show us the run of that LAD. I know it is difficult to appreciate on a webinar from images that you're showing us. And the next one. Okay, so I cannot see tram track calcification here. Now, one of the reasons, the reason why I'm saying this, I mean, the case is wonderful. The result is very good. One of my concerns is that we can overuse IVL because it is easy to use. If we are really using IVL, I think there are two things at least we should do. We should have optical coherence tomography, which should tell us the distribution and the thickness. That is very important. The thickness of the calcium and whether there is a calcium nodule or not, where the IVL may not work, which IVUS does not pick up all the time all that well. So since it is an expensive technology, you might as well do OCT to know exactly what you're doing. And the second is, it is very important, and this step, that suppose you did not have intravascular imaging, the beginning point is looking at the angiogram and seeing whether you can see calcium. And there is a classification of mild, moderate, and severe calcium. And here you should.
We can appreciate here a calcium in unilateral part of vessel, not
yes,
in both sides.
That's right. What
yes.
I said, what I meant was I could not see tram track calcium. There is probably calcium
so
on
tram
one
track calcium was in our first case.
No, I'm talking about this case. I'm talking about this case. So this is
There is not tram track.
Yes, this is the type of calcium. My point is that this is the type of calcium that could yield to high pressure balloon dilatation as well. And I would try high pressure balloon dilatation. And if it failed, I would have gone ahead and done what you did exactly. And my feeling
so
about
that is with NC balloon.
Yes, with an NC balloon, I would have done it. At least with a 3 millimeter NC balloon. In the proximal LAD, I am very comfortable in that osteoproximal area to use a 3 millimeter. Your IVUS images clearly show that it will take a 3 millimeter balloon proximally. I would have been very comfortable using it. I would have looked for the waist. If the waist went, then IVL is not required. That is my take on this case. And the other case, if you can show your intravascular images, IVUS images in the first case as well, please. The pre-image before you did the. Here we can see the tram track calcification in the mid LAD.
Yes.
Yes.
So actually, OCT was not available in our cath lab that time.
No. I appreciate that. I do appreciate. So we
have to depends on IVUS.
It is not a I'm just talking about what should happen ideally. You did your best with whatever tools you had. Just scroll back that image and show us where you think it is tightest. Here, so here, just freeze it there, please. Yeah, freeze it there. Where you think it is, you're seeing concentric calcium and it is very tight. There, maybe there. Stop there. Stop there. Wherever you think it is tightest, you freeze there.
Sorry. This picture is.
I see. Regarding so the picture that you have shown in the right. So if you measure it, see it is at least 2 millimeters across and 2 millimeters 1.5 millimeters up and down. And you need a sizable burr in this situation if you really want to ablate this calcium. And if you are using a smaller size burr, you might just buzz your burr through across the lesion and not do anything to it without realizing that it has worked or not. So if you see this, we see this often. And again, if the lumen is good, these lesions also, because you are not able to be sure from this image about the thickness of the calcium. And these sometimes yield to balloon dilatation. But
sir, we tried here with 2 millimeter balloon, but 2 millimeter balloon was not crossing through the lesion.
It wouldn't pass.
Yeah.
Okay. Now then it's fair enough. Okay, you did rotablation and then that worked, and that is that. Okay. Well, thank you very much. Both the cases are very nice. Regarding the proximal optimization in the proximal LAD, what size balloon did you use?
In this case, sir?
Both the cases, you had stents in the proximal segment of the LAD.
In this case, it was 3. And my second case, we optimized with 4 at high pressure, 20,
that was
24,
in the
as
that was in the
main
left
case.
main. That was protruding in the left main, right?
Left main, yes.
Yes. My point about the proximal LAD is that it is in most cases, the proximal segment of the LAD you can do with 3.5 balloon. It just gives you better stent expansion and decreases the chance of late loss in the proximal segment, because recurrence in the proximal segment is the worst thing that you can have in the LAD, and you cannot just treat them medically. You have to go in and do another intervention. So if you have a stent in the proximal LAD, try to dilate with a 3.5 balloon.
Dr. Devdatta, your opinion about use of IVL? It was 2.5 diameter in the second.
Yes, yes. That was the another point. Okay. So if you undersize, I think given your IVUS findings, I would have, I agree.
0.75 at least.
Yes. What can happen in this case, it did not happen in this case, and we have faced this, is we had used a balloon, slightly undersized balloon in an IVL case, and it had modified the calcium in such a way that it was very difficult to pass anything after that. And we were very intrigued by it. The IVL balloon had actually expanded, and then we could not pass our OPN balloons, and it was with great difficulty. In the end, we did, and we cracked it. But this can sometimes happen, that if you undersize your IVL balloon, it can modify or crack it in such a way that it deforms the vessel and makes your life more difficult. So I agree with this point as well, that probably I would have taken a 2.75 or even a 3.
It would have been better.
Yeah. Would you agree if I say that with IVL, we need to size 1:1, and with OPN, we need to at least reduce by 0.25?
Yes, I do agree. Yes.
IVL,
I think IVL is, I mean, I have faced this problem, and I am very wary now. We used that balloon because that was the only balloon that was available on that day. The IVL company, they brought 2 sizes which were not adequate for our case, and we had to use one balloon, and we got into this difficulty. I don't know whether anyone else has got into this difficulty as well, but we did, and we will definitely not do it again.
Actually, IVL is ineffective if it is not 1:1. It doesn't touches the calcium. It is.
Yes. No, you see, it is the effect. The lumen also matters. I mean, if it is just expanded within the lumen, in the lumen, it doesn't touch the vessel, then it doesn't work.
Yeah.
That is what you're trying to say, right?
Yeah.
Yes, I agree. Here it worked, but I mean, even if it works in such a way sometimes that it makes the passage even more difficult. That is my point. If you undersize it.
Thank you so much, Dr. Ahmed. And I would
one comment from me. Only one comment.
Yeah.
So even if you undersize, you've taken an undersized balloon, you can sometimes go up to 8 atmospheres and then deliver your shocks, and not at only 6 atmospheres. That we do sometimes when we undersize knowingly.
Yes, that you can do.
Again, not a very compliant balloon.
Yes.
So that won't be a good practice, I guess, because adding 4 atmosphere, and the IVL would give you another 46 to 50 atmosphere of pressure. That is what we are looking for. So if it's not a very compliant balloon. So it's always better that you size your IVL properly to get the best result.
Yes.
That's very important.
Yes. Yes. Okay.
Thank you so much. I think we'll move on to our next session of strategy to treat ISR. I would like to thank Dr. Davidson, Dr. Natarajan, Dr. Karmakar, Dr. Shahu, and Dr. Ahmed for the brilliant presentation, and Dr. Shah as well for the expert opinions. So we move on to our next set of presenters. We have 5 cases for this session. So we'll stick to the time of at least 10 minutes per case. And then we'll have 3 cases and some discussion. I think Dr. Pathak is, he wants to present the first case because he is to go for a primary, I believe. So Dr. Sushant Pathak from Ford Hospital, Patna.
Vinayak, I would just add, I would request our experts from the previous session to stay with us if possible.
Yeah.
So that we can take the benefit of their opinions and expertise.
Sure. And I welcome Dr. Devashish Ghosh, Dr. Vishwajit Majumdar, Dr. S.S. Padhi, Dr. Kuntal Bhattacharya, and Dr. Arnav Chaudhary for this sessions, for the expert sessions as well. So thank you. Let's start with Dr. Sushant Pathak.
Sorry, sir, I have to go to earlier for a primary.
Yes.
Secondly, actually, my case is regarding only the calcium lesion. It is not ISR. Unfortunately, my case was included in ISR. Recently done. 65-year-old male patient, hypertensive, non-diabetic, presented with chest pain of class CCS class 3, even after GDMT for last 1 year. His ECG was shows T-wave inversion in chest leads. Echo was normally function with grade 1 vascular dysfunction. Angiogram was done, which shows left main distal significant disease, LAD proximal to mid, heavily calcified significant disease. OM was in L6, OM was significant disease. RC mid part was intermediate disease. This is the angiogram we planned for the option was given for both for CABG as depending on the calcium load as well as but they opted for go for PCI. This was an angiogram showing a heavily calcified LAD and left main distal significant disease, mainly lesions, a culprit lesion in this case. Apart from the OM, we have a significant disease, but we planned for left main to LAD angioplasty. First of all, with the angio short is not visible. We do the pre-dilation with 2 into 10 mm because of the proximal. There was a significantly tight lesion in the LAD. So we are afraid of whether we get a stuck burr during rota. That's we do the pre-dilation with 2 into 10 mm Tazuna balloon. Followed by then use the rota burr of 1.5 mm. That we did. It was the maximum burr available in our lab. We did following which we choose again the result is not very optimized. We use the 2.75 into 10 Alvarin as well as 3 into pre-dilation was again done with 3 into 10 non-compliant balloon. This was the shot after all the pre-bed preparation, post rota and using cutting balloon. Then we planted 2 stent of 2.5 into 15 mm and 3 into 30 mm of it was Giants Expedition. First stent was placed distally, followed by another stent which was from left main to slide one. We have as the size mismatch was there. We have to give the more overlapping segment. It was just we have issue with our availability of the stent in our lab. Then we again the post dilation with 3 into 10 mm, 12 mm with the post dilation with non-compliant, followed by 3 into 5 into 8 mm post dilation with non-compliant balloon. This was the final result. still in the caudal we will see that we will not able to break the that calcium chunk. The most of the absent or poor result was that because one of all things we have at that time we have don't have imaging facility available in our lab at that time, as well as the absence of the high pressure OP-NC balloon. The presence of that may be helpful in maybe have get a result. Maybe it would have given a better result if we have imaging as well as OP-NC balloon that may help to the expansion of it lesion. This was the final shot. This was the only final shot. It was just prepared quickly, just try to one day only.
Okay, thank you there. I think you go and do your primary, and if you can come back, we will we'll sit down and discuss your case with you. Okay, Dr. Pathak.
Yeah, our next presenter is Dr. Madhuban Aja from AMRI Dhakuria. He's going to talk about IVUS guided PCI in a case of ISR. Dr. Panja.
So good evening, sir.
Good evening.
Yes, I'll just share my slides. Sir. So I have an issue with my PC. I've already informed them before, but I'll try to. So can you view my slides, sir?
Not yet.
No, we can't.
Okay, sir. So now?
Yes.
Yes, we can.
Slideshow.
Yes, sir. So there's a problem with my slideshow only because that's right.
Click on slideshow.
Carry on with this, Dr. Panja. There's no problem.
I've already told them before. But I can see the maximized slide, but I won't be able to. But I'll try again, sir.
You're not clicking on the slideshow. Just click on the slideshow. You're clicking somewhere else. Down on the bottom right-hand corner below. Click on the slideshow. Not there. Below.
Just try.
We can see your pointer. Bring your pointer down to the right bottom corner.
The 74% where it is written.
Below, by the side of 75%. Click there.
Or you press F5.
F5. Yes, sir.
Yes, got it.
Yeah, we can see it.
Thank you, sir. So my presentation is IVUS guided PCI in the case of ISR. So this is a short clinical history about the patient. She's a 80 years old female, known case of hypertension, obesity, COPD and dyslipidemia. The patient presented with unstable angina and shortness of breath on exertion on 14th of Feb of this year, 2022, after 19 years. The previous intervention was done in 2003 by BMS, one at the proximal LED and one at the mid LED, and there was no overlapping of stents. Subsequently, she presented with acute coronary syndrome in 2011 and diagnosed as ISR and managed by POBA. So I advised the patient for CAG. Left vein was normal. LED showed diffuse narrowing with calcification from proximal to mid LED. The patient was diagnosed as ISR of both the stents and LED. The LCX was normal and dominant, RCA was non-dominant. So our plan was the hardware selected were 7 French EBO, C on blue wire, cutting balloon Wolverine, NC balloon, drug-coated balloon sirolimus, and it was done IVUS guided. So post CAG, this is the IVUS finding. Distal part was healthy. The tightest part was the mid part. Minimal lumen area was 3.9 millimeters square and the plug burden was 64%. The lesion was crossed with C on blue wire. The neointimal proliferation was treated with the drug-coated balloon 2.5. I'm sorry, a cutting balloon, Wolverine balloon 2.5 into 15. And this balloon was inflated at 14 atmospheric pressure. This is the IVUS after use of cutting balloon. You can see the minimal lumen area that was before the use of cutting balloon, it was 3.9 millimeters square. After the use of cutting balloon, the minimal lumen area increased to 6.06 millimeters square. Since it's a case of ISR, hence our objective was to reduce the further metal load in the artery. So the lesion was treated with 2 DEB. One drug-coated balloon at the distal end, it was 2.75 into 40, and one at the proximal end, 3 into 35, inflated at 20 atmospheric pressure. So this is the final result after use of drug-coated balloon. So on discharge, we discharged the patient on ticagrelor 90 BD and icosapent 75 OD for 6 weeks. This was followed by clopidogrel 75 mg OD and icosapent 75 mg OD for 6 months. And after 6 months, our plan is to continue with clopidogrel. Our take-home messages since last 19 years, that is from 2003 to 2022, the patient was doing well with BMS, but ISR developed in 2011, which was managed by POBA. Recent development of ISR was in 2022 of both the stents in LED, which was managed by cutting balloon, followed by NC balloon, which was again inflated by 2 DEB. So it's a long diffuse ISR with some degree of calcification, 180 degree, which was managed in a very simple way. Thank you, sir.
Thank you, Dr. Paja.
Yes, sir.
Dr. Bhattacharya, do you want to take some questions?
I think we'll go on to the next case. We'll
next presentation. Okay.
Yes, and
so it is by Dr. Sumon Chatterjee, who's from BM Birla Heart Research Center, Kolkata. So over to you, Dr. Chatterjee, for your presentation.
Good evening, sir.
Good evening.
I am going to present 2 complex cases.
Your time is 10 minutes, Dr. Chatterjee.
Yes, sir. I will try to cover up within 10 minutes. So my first case is My two cases are one from calcified lesion and another is CTO lesion. First cases is a calcified LED lesion, 75-year-old hypertensive male presented with acute coronary syndrome. He has a significant HTT changes with anterior pictorial reach in CG and echocardiogram shows good LV injection fraction without any RWA. Now coming to the coronary angiogram, he has a long left main, short left main. He has a short left main with a calcified proximal to mid LED lesion with aphasia in between, and he has a left dominant suppression. There is little bit of thrombus present in the LED also. So we took the rota in these cases to radial route only. So we took a 1.5 millimeter rota bar and done the rota ablation in the LED. And then we pedilate the patient with a 2.5 millimeter balloon, and this is the short post rota injection appearance of the LED.
Sir, your sound is not coming properly.
Can hear actually, Dr. Nag.
Am I audible?
Yes, you are audible. Strategy, continue.
So then after rota, we done the pedilation with a 2.5 followed by 2.75 millimeter balloon. And after that, we have deployed a base 3 into 38 millimeter from proximal to mid LED. After that, we have done a post dilation with 3.5 millimeter balloon, NC balloon, and this is the final result of the LED lesion after stenting. And this is how to tackle about the calcified lesion with a rota ablation. And now coming to the next case, 58-year-old male, hypertensive, non-diabetic, had a old MI 1 year back. His echocardiogram shows poor LV system function with LV 40% with grossly hypokinetic anteroseptal wall. But patients have an on and off post-infarctal angina, which was aggravated recently. Angiogram shows a double vessel disease with a CTO RCA. We initially referred the patient for CABG, but patient denied it. So we planned for a PTCA in view of his persistent angina. And this is the angiogram. And this is the LED lesion. After fixing the LED lesion with the base, that will go into the right side of the CTO lesion, the CTO RCA, and we'll take a contralateral shot for visualization of the CTO segment. Initially, we thought it was a functional CTO with a short segment, but after trying with a whisper ES-square, we are unable to negotiate the CTO segment, so we changed our plan. We took a microcatheter with a Gaia 2 wire, and then ultimately it was the lesion. Then we introduced the microcatheter and exchanged the Gaia 2 wire with a Sion blue wire. And after that, pedilation done with a 2.25 into 15 millimeter balloon, and followed by this deployment from proximal to mid RCA with 2.5 into 38 millimeter base. And this is the final result. And thank you.
Thank you, Dr. Chatterjee. Dr. Bhattacharya, Dr. Vishwajit Majumdar, HOD from Arteries Hospital, has joined us, and Dr. Arnab Ghosh Chaudhary from Hospital Vivekananda Hospital, Durgapur, has also joined us. So if you can.
Okay. You want to take some comments from our newly joined experts?
Majumdar?
Is Dr. Kuntal Bhattacharya here?
No, he is not here.
Okay. Are there any more cases to discuss?
Yeah, 2 more cases.
All right. I think we might just take a short break here and discuss these three cases quickly. I would invite Dr. Davidson to comment on the first case, which is the case with the rotablation, which was done without intravascular imaging. And in the end, there was some problem, I think, at the site of the overlap of the two stents, where there was the titus stenosis. And I would like to have his comments on the technique of rotablation that was used. I think only one run was shown. Dr. Pathak, is he still with us or he is gone?
He is left for the primary.
Okay, maybe we'll discuss his case later. Dr. Davidson, would you comment on the case, on the last case where rotablation was done?
Yes, sir. Yes, sir. Just a comment on that particular case regarding the rotablation, wherein we saw that the procedure was done through the radial approach. I believe that is French guide catheter, and
it was a 6-pin guide catheter.
That
So
is
that's
6
why
French
we
guide
took a
catheter. Yeah,
no,
yeah.
You're talking about the first or the third case?
The last presentation,
the last
he
one.
had two
Dr.
cases.
Suman Chatterjee's case.
Yeah,
Yes.
Dr. Chatterjee's.
Yeah.
Only thing that it's just a technical point. We saw that during rotablation, during Dr. Chatterjee's rotablation, the wire was actually in the mid-LAD, and you also had the lesion in the mid-LAD. And at some point of time, we saw that the burr was almost touching the distal radiopaque marker.
Yes.
Now, when this happens, it's always challenging to get the wire distally into LAD. So many times we've seen people removing the burr from the vessel, pushing the wire more distally, and then feeding the burr into the guide catheter. That really needn't be done. Now, in this particular situation, when the wire keeps coming out, what you could do is either during rotablation, while doing rotablation, the secondary operator or whoever is supporting you can press onto the brake defeat and push the wire. During the rotablation, press the brake defeat, the wire is released, and then push it across so that it goes more towards the apex. Or it could be done, you can move on to the Dynaglide mode, wherein it's a safer way of doing that. Switch over to Dynaglide mode. When you go to Dynaglide mode, keep the rotation, the burr static at one particular area. Again, press the brake defeat and push the wire distally so that the wire would go much distally. It's an extremely easy way of getting the wire distally in the LAD when the wire comes out during rotablation.
Yeah, that is an excellent point. Yes, that is an excellent point. I think, I mean, that there was a problem with that case because that wire was coming out. I think there was a guide catheter support issue as well. So as he was advancing the burr, the guide catheter was falling out a bit and it was taking the wire out. And it is not safe to burr that region without the wire in the distal LAD. So I think that is a point that is very well taken. I think Dr. Suman Chatterjee,
yes,
you would agree with this. And
yes, there is a issue with the guide catheter. That's why that was happening. The left end was very short and the guide catheter was not up to the mark.
Yes, yes. And the other thing is, Dr. Chatterjee, I think if you are doing rotablation, try to do intravascular imaging, because that will improve your insight of calcified lesions and what your strategy really should be. Without intravascular imaging, just looking at the angiographic calcium, you are not totally aware of the complexity of the lesion. So I think BM Birla does have intravascular ultrasound. So please try to use it in your cases. Okay, the next case, the Dr. Madhuvanti Paja's case, I think Dr. Natarajan, if you would like to comment on that case.
I just wanted to ask her, what was the mechanism of the restenosis in that case? Because we didn't see any stent under expansion.
No, sir, it's new intimal proliferation, sir, in this case.
Yeah, Madhuvanti, I think what I saw from your, you presented the case, the first angio that you showed us only the epicranial view. You didn't show us the other view.
Yes, sir. Yes, sir. Yes,
so
sir.
Angiographically, we really couldn't assess how the vessel moved in different projections.
Yes,
and what little I could see from the epicranial view is that there was what we call very tight instant restenosis that was not there. from that view, but it could have been there in other views. That is
Yes,
why
sir.
I'm asking
Yes,
you
sir.
should have shown us the other views so we could have appreciated it better.
Yes.
The other thing is, tell me something, when you did the intravascular ultrasound, did you do any pre-dilatation or you just went in with the intravascular ultrasound?
No, sir. We did first we did IVUS. After that, we did
Without,
pre-dilatation.
okay,
Yes, sir.
without pre-dilatation, you went in with that.
Yes,
That is fair enough. You can do it if your
IVUS,
probe
yeah.
would pass. So my point is, looking at that run, there was only really one very small, very tight area, and the rest of the stent was not that badly not that badly stenosed. So I think probably that area that you showed, that which was 3.9 millimeters square, that I think that was all that needed dilatation. And although there was, after 10 years, there will be some late loss. That late loss probably would not have required that two large DEBs. The elderly lady would have been okay without it. And if you just address that, I think that would be enough. Okay, and yeah,
anything
and
particular
anyone
choice?
else? Yes, yeah. Go ahead.
Sorry. Any particular choice why sign blue was taken?
Sorry, sir, I couldn't hear you, sir. Any particular choice?
Sign blue wire, guide wire was chosen. So any particular reason for that?
No, sir.
Because I guess this stent, if it was in 2000, 2001, it must be cipher.
Cipher stent.
Yeah.
Yes, sir.
That is known to have aneurysms around it, and then cyan blue probably may not have been a good choice for that.
Okay, sir.
We can keep tracking into those aneurysms.
2001.
Dr. Majumdar, do you have anything to say?
She said it was bare metal stent, I think.
Bare metal stent.
You said bare metal stent?
First one was BMS.
Yes. And second time you did a POBA.
POBA.
Yes. So there is only a single layer of stents there.
Yes, sir.
Yeah. Okay. Yes, I mean, your point that you do not want to put more metal in, that is very well taken. But from what you showed us from the intravascular imaging,
I should have shown the...
Yes, a more focal
yes,
tackling of that stenosis probably would have been enough instead of those two large drug-eluting balloons.
Yes.
Dr. Bhattacharya, sir?
Yes.
So a small clarification regarding the comment that you made to the previous presenter about the value of IVUS in understanding the complexity of the lesion post-rotablation. I just want to know...
Pre. I wanted him to do pre. Before starting IVUS, before starting rotablating, I wanted him to do the IVUS. From what I could understand from his angiographic appearance was that there was a lot of angiographic calcium, but probably if he did IVUS, he would have realized that rotablation probably might not have been necessary because of the calcium distribution. I could be wrong, but you can be sure only if you do intravascular imaging to look at that. IVUS, I know it has its limitations. It doesn't show you the thickness of the calcium, but it does show you whether it's superficial or whether it's deep. And if it is deep calcium, balloon dilates, I mean, then you can go ahead without doing rotablation. That is my point. And
you were suggesting that rotablation may not be necessary in all such cases.
Yes. I mean, if you are doing it, if you are taking the trouble of doing rotablation, try to pass the IVUS catheter down and take a look at the vessel. If the IVUS catheter doesn't go, it is an indication for rotablation. That's the end of it. But if it goes, then take a look at those pictures and decide what to do, whether it's IVUS, whether it's balloon dilatation, whether you want to do IVL. That is my point.
Thank you.
So regarding Dr. Panja's presentation, it's almost 20 years down the line regarding the following the first angioplasty with a bare metal stent. So could that be, we saw that there was significant amount of calcification also in IVUS inside the vessel, inside the stented segment. So the mechanism of restenosis probably, it's anyway, it always starts with neointimal hyperplasia. But when you see significant amount of calcification inside the stented segment, it means that we are moving much away from neointimal hyperplasia, more towards neoatherogenesis. That is, you have neointimal hyperplasia, then you have vascular neoangiogenesis into that, then you have macrophages coming in, then you have calcium deposit. So once you have calcium deposit, it says that it's more of neoatherogenesis.
Yes. You are, Dr. Davidson, you are, yes, your
bandwidth was not
stopped. Yeah, I think.
So shall we move on?
Yes, we'll move on. Just what Deepak was saying is very important.
Sure about it.
20 years down the line, it is more likely to be neoatherosclerosis than neointimal hyperplasia, the classical instant restenosis appearance that we see. And again, optical coherence tomography would give you a much better idea. But even from that, if you look at the amount of calcium, this is more likely this is neoatherosclerosis. Yes. Good point.
That makes it a case for new stents to be deployed. That's what you're trying.
Yes, that's what I thought.
Yes, I mean, you see, even if it is, the tightest area was 3.7 millimeters square. I mean, she's 80, and if you looked at the angiogram itself, probably you would say, I wouldn't do much in this lady, you know, unless the patient is really symptomatic. And it is a very long segment of stenting. It is a 2.5 millimeter distally. I mean, I would have to be really, you know, I have a very good indication of going in with a stent again there. But I think whatever she did, she achieved a good lumen area, and there is a drug coating there now. So hopefully she will be okay. And we have to also consider the fact these are high bleeding risk patients. So if you give them a stent, you will be obliged to give them DAPT for a while, which may not be in our best interest. So I think that there is that argument in favor of that. Okay, Binayak, over to you.
Yeah, we'll move on to our next case by Dr. Raja Nag, consultant interventional cardiologist at Apollo, Kolkata. So over to you, Dr. Nag, for your presentation.
Thank you very much. Let me share my screen.
Raja is going to show instant restenosis. Is this the
Devdatta sir has already seen that.
This is a very good case. Very good case. Show it.
So I didn't have any other choice. So they informed me in the last 2 days. So
yeah,
he said, okay, I'll show this, but I didn't know Devdatta sir will be around.
No, it is a good case. Show it again.
Yes, sir. Yeah.
Slide share is
করছি প্রবলেম হচ্ছে উপরে ড্রপ ডাউনটা করছিল না
there you are.
The drop down করছিল না. So my case, this is the second time I'm showing to Devdatta sir. The others may be seeing this for the first time. The patient is a 70-year-old male, non-smoker, hypertensive, non-diabetic. He has a long history and association with coronary artery disease, and starting from 1999 when he underwent a bypass with 3 grafts of Lima to LAD, venous graft to OM and diagonal. Then he was doing quite well till 2011 when he had occlusion of his venous graft to the diagonal, and he underwent a PTCA and a DES to his venous graft. Again in 2015, he had a native vessel disease of his RCA, and for which he underwent a DES in 2015. In 2018, again, he had underwent stenting of his venous graft to the OM, and after that, he was on medical management. In the first part of the pandemic, he presented to me with acute LVF, and he was hospitalized and with the ejection fraction of 30%. He was on BiPAP for some time, and we decided to put him on medical management. His creatinine was on the higher side, so I decided to keep him on medical management and not do any further angiogram. He was doing quite well with all these newer group of drugs like ARNI and SGLT2 inhibitors. And then in 2021 again, he presented with severe teeth and jaw pain on mild exertion. So this time his ECG showed atrial fibrillation with controlled ventricular rate and ejection fraction of 45%. Creatinine was still on the borderline with 1.4. Medication C was optimized. And then we did a CAG for him. This was his native vessels. So like you can see, his stent to the RCA has a critical instant restenosis in the mid segment. And from the angiography, I don't know whether you can make it out from this small screens. There are evidence of calcium from this also. It was almost a subtotal occlusion. So we did the venous graft angiography also. So these were all patent and flowing. So the next plan was to discuss with the patient and do a PTCA or a DEB stenting of his instant restenosis. So we decided to go with OCT, and this time a femoral root with a 6 French JR, 2 wires. Wiring was not difficult. Initially, we took a small balloon and tried to pre-dilate with a 2.5 12 NC. With that, we could see there was quite an amount of waste even with the 2.5 balloon. And I went up to like 24, 26 atmospheres pressure. So it was not giving me. So then I did this because my OCT catheter would not go through, by the way. So this was just to make a passage. This was just to make a passage to allow my OCT catheter to pass through. And this is the OCT run. Like you can see, there's a lot of new atherosclerosis with some amount of calcium which was not exceeding more than 180 degrees. And the restenosis part was from the mid segment up to the proximal edge. These are some patterns of the instant restenosis which have been described by Mehran et al. And we took the, by the MLD algorithm, we did his assessment of the OCT images and then decided to do the debulking. So this was an angiosculpt 3.10 millimeter. It did its job, but like you will see, the more proximal part, the lesion did not give way. So we took a 310 OPN balloon and went up to the highest pressures. So if you see, gradually this gives way, and then in the next image, it has opened. So after this, I wanted to see whether we have cracked the lesion and gained enough lumen to put in my second stent. So did a OCT run. So this was my OCT run, which showed some amount. There were good cracks in the narrowest part, but there were some amount of calcium still present in the 6 o'clock and the 12 o'clock position. So we decided again to go in with an NC balloon, this time with a 3.5 and crack the lesion. So this was a 3.5 again. So this time it looks like it has given. So I was happy with that and put in a 3.528 drug-eluting stent. By the way, the previous stent was a 3 diameter stent. So this expanded well angiographically. It was dilated. This is the final result. So these are the final OCT images. The expansion was almost 134%, and the stent achievement area was more than 7. So we decided to leave him at that, and he's still on follow-up, and he's doing well with medications. So mechanisms of DES restenosis have already been discussed in detail by my previous senior speakers. The treatment of ISR algorithm, everyone knows about that. So to conclude, the management of patients admitted with ISR and stent thrombosis is challenging. Interventional treatment has failed once. There is often underlying causes that lead to this event. The event rate also is very high following the second PCI. OCT or IVAS, or preferably OCT, should be routinely used in such ISR patients to identify the pathology and the cause of ISR, which helps in the guidance of treatment and evaluate procedural results. Thank you.
Thank you, Dr. Nag, for your excellent presentation. We'll move on to our last presenter, Dr. Siddharth Omani. and then we'll take some questions. And Dr. Mani, Dr. Mani is a consultant interventional cardiologist at Arentagor Hospital. And over to you, Dr. Mani, for your presentation.
Yes, thank you, sir. Good evening. Let me share my screen. So I was asked to show us case on calcification. So this case is complex by its own merit by the location and the LMCA bifurcation, but I tried to do it in as simple way as possible, leaving some scope for discussion as well. This was a 83-year male hypertensive diabetic presenting with CCS class 3 angina, ejection fraction of 50% with inferior wall hypokinesia, and slightly reduced renal functions, a creatinine of 1.7, and has a COPDS comorbidity. So this was the left, the RCA was a non-dominant one, so I'm leaving that RCA. This was the left main bifurcation in the which I was going to approach, and so I took a XB 3.57 French catheter because I had already planned for a dedicated bifurcation strategy. As you can see that it is involving both the LCX and LAD ostium and also the distal LMCA. Now, obviously, between the two-stent strategy versus provisional side branch stenting, this case merits two-stent strategy because it is obvious that doing one, stenting one side will pinch the other side significantly. So now the question was, what should be the strategy? Ideally, we all know that in such bifurcations, decay crush is the mainstay of therapy, but here I differed a bit because there was so much calcium in the LCX ostium. I was very skeptical that if I will crush the LCX stent and then if I fail to rewire it through the double layered crushed stent struts, so that can result in a in a mess. So I thought culotte would be a safer option, and the angle here was more or less favorable. The angle, the comparable diameters of the left main and the two branches, it was more or less favorable for culotte as well, and it would be easier for me to recross. So I went in for culotte. IVAS and OCT, obviously OCT was a better choice here, but I did not have at that time OCT console was not present in our hospital, so I had no other option but to choose for IVAS. And rotablation was not a good option here because it was left main and it was a bifurcation lesion involving both the ostium. So I had to choose some alternative calcium modifying strategies. I began with run through wires, and I had to take a 1.5 millimeter balloon support to cross it. It was quite difficult to cross because of the calcium and tortuosity, and it was extremely tight in the mid portion. So ultimately I could cross it, and after that I did a daughtering and pre-dilatation with a 1.5 millimeter balloon throughout the LCX to create some space for my imaging hardwares and for my further upgrading the balloons. So I gained some lumen area. You can see that the mid part of the LCX, which was completely almost invisible, it's now showing some lumen and the branches are a little more prominent to me. The orientation of the vessel also is a little more prominent to me. Then I took a 2.5 millimeter balloon pre-dilatation throughout the LCX, starting from the mid-distal junction to the mid and proximal part, and then I wired the LAD, and I put another wire into the LAD. So now I did IVAS in both LCX and LAD, and I will show you both the IVASes. So this is simultaneously running the IVAS in the LCX on the left hand side and the IVAS in LAD. So obviously the LCX is much more narrowed, calcified. The calcium arc is almost 180 to 270 degrees, and in some places you will see that it is almost completely circumferential, involving almost 360 degrees. LAD was not looking that bad. Also, there obviously there were some areas of eccentric plaques, calciums, fibrotic lesions, but it is not as bad as the LCX. It was also evident in the angiogram as well. So our IVUS image corroborates that. So you can see the tightest areas, and as we gradually encroach the left main, so I had a lot to work on this calcium, particularly in the LCX. That was obvious from the imagings. So let me now move on to the case. Now I took a 2.75 millimeter balloon, 2.75 millimeter balloon to dilate the LCX ostium, which was the tightest portion. And you can see that the balloon is expanding quite well. So now I took a 3.5 into 38 millimeter stent in the LCX first. It was because LAD was the major branch. So traditionally we will stent the side branch first. You can see the expansion of the stent. It is not that bad, more or less up to my expectations. And I had come up to the mid shaft of the left main. So this is the immediate post-stenting results. Obviously, it is not perfect, but also not, it is quite satisfactory in the LCX particularly, considering the initial very extensive disease, calcified disease, which was present in the LCX. Now I had to recross. So recrossing was a bit difficult. You can see I had to struggle a lot to recross into the LAD, and ultimately I could do it. So then there was a post-dilatation in the LCX ostium coming up to the left main with a 4 millimeter balloon. And here also the balloon expands more or less well. So going on well up to this part, no complications. Now I had to open the struts. I took a 2.5 millimeter balloon to open the struts to negotiate my balloons and stents into the LAD. And then after the 2.5, I had a further dilatation of the strut with a 3 millimeter balloon to make further, further area, because I have to take in quite a good sized stent through it. So following this, I introduced a small LAD stent, as small as possible, considering a more or less proper landing zone in the prox mid junction of LAD. And it was a 3.5 millimeter into 24 millimeter stent, and I just came in by 2-3 millimeters into the left main. So this was the expansion of the LAD. You can see the calcium. You can see the calcium hindering the expansion of the LAD stent eccentrically in the lateral part. This was the immediate post stenting results, and it is also not looking that bad, particularly the LAD and the bifurcation point, the point of confluence, it is more or less okay. So now the last part, coming to the kissing balloon dilatation in the LAD and LCX. So I took 3.5 millimeter balloon in both LAD and LCX, and went for a simultaneous kissing dilatation, and this was the final result. So considering the initial very poor status of the LAD and LCX, I thought it was looking more or less decent. So that's it from my side. This is the final LCX, IVUS run in the LCX. And you can see in the right hand side, I have shown the ostial part of the LAD and LCX. I will show you the carina as well in the last frame. So the stent appears. It is more or less well expanded and apposed. Obviously, considering the huge bulk of calcium there, it will not be a perfect circle. There will be areas of eccentric expansion of the stent, but I have to accept that. So some of the branches you can see throughout it is well opposed. Obviously, OCT would have been a better choice, but as I said, I did not have a available OCT at that time. It was a long stent. And this is the carina. So this was the carina. So that's it. Thank you so much.
Thank you, Dr. Mani. Bhattacharya, you can.
Okay, so this is yes, I gathered that we have come to the end of our presentations, and
Yes.
I think has Dr. Pathak returned, or is he still busy with his case? In which case we will not discuss.
Not come back yet.
Okay, so we'll take up Dr. Rajanag's case first. Raja, if you can, is Dr. Deepak Davidson still here?
He is there. Dr. Shajit Majumdar is there from RG Medical College.
Raja, if you can.
Is there.
Okay, we will get everyone into the discussion. So Raja, if you can play your, Deepak, are you here?
Yes, sir. Yes, sir, I'm here.
Okay, so Raja, play your first pre-stenting OCT run. So you skip through that run quickly. Show us that run, and I would ask Dr. Davidson to interpret it for us. Can you hear us, Raja? Dr.
He's
Raja.
left actually. He's left.
Okay, well, that is a pity. In which case we'll go on to discuss Dr. Mani's case. Siddhartha, if you can show us your circumflex run pre-stenting. So you have pre-dilated the circumflex, and now you are doing an IVUS run, and show us that IVUS run, and let Deepak interpret the IVUS run and what strategy should be taken. Your strategy was, by the way, exactly the right thing. I agree with what you have done to this circumflex. We'll discuss what you did with the LAD, but the circumflex, let's see the circumflex run, pre-stenting.
Yes, sir.
Dr. Davidson will interpret it for us. Yeah. So you have pre-dilated it, and now you are showing us, just click on the circumflex. Don't click on the LAD. Don't click on the.
Okay, I get it.
Yeah.
Yes. So the only thing is I'm not really able to make out the vessel size. I would always want to see the vessel size. The markers are not there in this image. Yeah, we could see that.
You can barely make out the transducer, so that is 1 millimeter.
Yeah, 1 millimeter. It's a huge vessel. The circumflex, the left main as well as LAD is all looking so huge. The circumflex looks almost 3.5. The left main looks almost 5. And this circumflex pullback, there is very critical stenosis. Lot of islands of calcification can be seen. But till now, we never saw that there was some 360-degree arc of calcification. We are able to see that it's almost 90-degree arc of calcification. I think the run is over, right?
Yes, almost over. We are into the left main.
Can we see that once again? Yes.
Yes.
Yeah.
No, that's the left main, I think. Yeah. So
yes. Now we have come to the circumflex ostium, wherein it's almost 180-degree or more than 180-degree arc of calcification. So we know that it's a very significant calcified, significantly calcified vessel, almost 270-degree arc, as Dr. Siddhartha Mani has mentioned. That too more towards the ostium of the circumflex, not too distally. So we saw that the pre-dilatation was done extremely well. I thought that probably this should have been a bit more bigger sized balloon based on the IVUS evaluation. Sir, one more thing that regarding the choice of stenting in this particular situation, I would also agree with you that I would also prefer using a 2-stent strategy because LAD ostium is significantly diseased. Circumflex is also significantly diseased. Now, could you tell us what was the reason why you decided over QLOT compared to
Yeah. Deepak, we'll come to that. We'll come to that. One. Yeah. So yes, that is the thing. Siddhartha, I think it looked much worse on the angiogram, that calcific segment on that circumflex when you were wiring it and ballooning it, and we were expecting that it to look much worse. And this is the beauty of IVUS. So once you have done it, you quickly realize that this will yield to balloon dilatation. And even before you did balloon dilatation, I was sure that it would. And I agree with Deepak that I would have probably taken a bigger balloon to prepare this, because this is such a huge vessel. And if you prepare it well, if you dissect it a little bit, it shouldn't matter because you're going to stent it. And as you said, after you had deployed your first stent, there were some portions of under expansion. So it was a 3 or a 2.75?
So I took the cutting balloon 2.75.
No, the stent, I mean.
No, stent was 3.5, I think, sir. Just a minute. It was the cutting balloon 2.75 for the ostium, and yes, it was a 3.5 millimeter stent, sir.
Okay, yeah. Okay, fair enough. I think the cutting balloon, given the IVUS measurements, you could have taken a cutting balloon, a bigger size cutting balloon there. And this is a Wolverine, right?
Yeah.
Okay.
So just because the LAD ostium was also having significant disease, I thought that if I use a bigger size cutting balloon and if I dissect the carina and if I do some gross injury to the LAD ostium, maybe I won't be able to carry further with the entire bifurcation process.
You wouldn't have. The LAD, it is diseased, but the LAD, there is ample space in the LAD to do whatever you want later on. I think a 3 millimeter balloon you could have easily done it with a 3 millimeter balloon, but whatever, you did it with a 2.75 and you achieved a reasonable lumen area, and after that the stent went in. So which brings us to the next question about your strategy regarding the stenting of the LAD. So you took that stent into about 5 millimeters or 6 millimeters into the left main, the circumflex stent, I mean. And then what you did look like a provisional stenting of the LAD, right? And you did not do a culotte. So the question I think Deepak wants to ask is, why did you choose this strategy and why didn't you go for a culotte? And why didn't you stent? We will come to the pot part last. So if you can explain to us your choice of strategy, then we can take the discussion further.
Yes. So, sir, first I already told you a bit that I predetermined for, not doing decay crush because I was.
That is fine. You didn't do decay crush. We are very happy with that. And
yeah. So now regarding culotte, I made a little bit modified it in a sort of something like mini culotte or something, although there is nothing as such, but because the left main was a very small, it was not a long left main. I had already put my previous stent into 4 or 5 millimeters into the left main, and then I had hardly another 4 or 5 millimeters left from the ostium. So if I was going to take my LAD stent further proximal to that stent, which should be done in a culotte, so I will almost reach the LMC ostium, which was disease free. I have already seen in the IVUS, and then maybe if I leave the ostium of the left main, that will be something I should not do, leaving 1 or 2 millimeters unstented. So that was something going on in my mind, that whether I should take my LAD stent further proximal. So with that doubt, I left the stent slightly, just 2 or 3 starts into the previous stent. So I just little bit modified my strategy. I was also aware that it was not exactly the traditional teachings, but I little bit modified it, thinking this in mind. So I am ready to take your opinion, sir.
Yes, there are some technical considerations here. Maybe Deepak can come in and give his opinion, and then we can invite our other experts to give chip in as well. So Deepak, quickly, what you would have done for this case?
Yes, sir. Sir, my preferred choice would be DK Crush, but I would definitely agree with that QLOT is a good option in this particular situation. While doing QLOT, probably certain things I would have done differently. Is number one, he has done IVS evaluation, made out the vessel, evaluated the vessel very well, prepared the vessel very well, and then selected the stent. And now regarding the point that you had just been mentioning, regarding the positioning of the stent in the left main. The left main is looking almost 8 to 10 millimeters, 8 millimeters or 10 millimeters. I would have probably, even though the ostium is not diseased, I would have probably taken it till the ostium of the left main, hoping that I would have enough position for the pot balloon. Here, the left main is looking a huge left main. Ultimately, we had to be satisfied putting in a 4 millimeter balloon from the left main into the circumflex, which was absolutely perfect for the circumflex ostium because it looked 4 millimeter and it was post dilated with a 4 millimeter balloon. But for the left main, that 4 mm, probably I thought it was little bit undersized. So if I had the stent till the ostium, probably I would have done a proper pot with a 4.5 millimeter balloon in the left main. Now that is point number one. Point number two is after deploying the stent inside the circumflex from the left main, we saw that the LED was flowing well. So even though I start off with a QLOT strategy, I would have modified my technique like what Dr. Siddharth has done, modified it into a tap technique. While doing a tap technique, I would have had a some balloon inside the circumflex ostium while positioning the stent, and I wouldn't have come back 2 to 3 millimeters into the left main. I would have positioned it right at the ostium with 1 millimeter protruding into the left main and did a final kissing balloon dilatation with the same both balloons over in the LED as well as the circumflex. Now, since Dr. Siddharth has the stent positioned in such a way that the stent has come almost 3-4 millimeters into the left main, I thought that probably you should have recrossed it into the circumflex and then did a kissing balloon dilatation and a final pot.
Yeah, that I did. That I did. I did not show that.
Okay,
Yeah,
okay. So
yeah, I think Deepak, excellent points. Siddhartha, I think you would agree that there is a problem with this proximal optimization with this technique, and you were not able to do this. The left main is very, very large, and you ended up just
the final pot I could not do because I did not have the length. Yeah.
Yes, this is just the technical consideration for this case, and why I would agree that you should come more into the left main, and then you did a modified you did a tap, and that is fine, but you would have had the opportunity to optimize the left main. So I think Dr. Binayak Dev, would you like to invite the other experts?
Dr. Vishwajit Majumdar, would you have any comments on this case, please? Dr. Majumdar? Robroto, is Dr. Majumdar here? Dr. Arnav Ghosh Chaudhary from Vivekananda Hospital, Durgapur, if you have some comments
Yes,
on this case.
Yes, sir. Good evening, sir. Yes, regarding this last case, sir, I had the same notion that LM stenting means LM to L6 stenting that should have covered from the ostium of the LM when the final pot should have been done. Because here we have a very good result in L6 and LED including ostium, but the size of the LM is much bigger. So the 3.5 millimeter stents without doing a pot, keeping inside the LM, definitely it can be underexpanded. And here we couldn't do the pot only because we didn't have a good amount of proximal length of the LM stent. It was only 5 millimeters.
Dr. Srivastav, your final comments and then we'll close.
I guess, sir, it is already discussed quite a lot, and probably everyone is speaking in the same line as Dr. Deepak Davidson has spoken. Probably Dr. Arnav has spoken the same thing. And I guess I also would have extended it to the left main, and the mismatch between left main and other stents probably would have been avoided. It would have needed a good pot in the left main.
Okay, thank you so much. So, Dr. Bhattacharya, I think we'll close the session. I congratulate everybody, all the speakers for their excellent presentations, and special thanks to Dr. Deepak Davidson and Dr. Srivastava for staying through the entire session, and Dr. Bhattacharya for conducting this course. So hopefully we have learned a lot from these complex cases. So with all these words, I say good night to everybody. And